I'm Diah Saminarsih. I'm founder and CEO of Center for Indonesia Strategic Development Initiatives, or CISDI, in Indonesia. In most developed countries, so in particular developed countries in the Nordic, the UK, the Netherlands, they have developed their health system and their focus on primary healthcare before the pandemic. So when the pandemic hit, they are quote unquote more or less better prepared because it's a system that they activated once it has experienced a shock. If we compare it to this part of the globe, Asia and Southeast Asia, we can compare between Thailand and India and Indonesia. So India and Thailand has very similar strength or strong points in primary healthcare system, which is their community health workers, or known as health cadres. The government of India recently received an award from WHO focusing on the work of their cadres, their health cadres. In Thailand, that is also similar, where they were ahead in pandemic response because there is a system already set up before the pandemic that the government activated once that's the pandemic broke. And the backbone of that system is actually the primary healthcare system, including the health workers in primary healthcare, and the most important is the community health workers, or what we know as health cadres. So they did the outreach. This is similar to India and similar also to Thailand. They are both comparable, where they have capacity to do outreach, capacity to do screening at primary healthcare level, and it supports and strengthens the system, the primary healthcare system. Indonesia, on the other hand, was a bit behind because primary healthcare, although it existed, it was not the focus of health sector development. So health system, national health system, and primary healthcare was not the focus of health sector development. And when the pandemic hit, they were not well equipped. Health workers didn't know what to do. Community health workers didn't know how to do screening and outreach in a pandemic situation. So in normal, peaceful condition, they are doing it very well. But when there is external shock, they didn't know what to do. This is what is different than the situation in Asia and also in other countries like the European that is more advanced in their primary healthcare. So Indonesia started our primary healthcare system since the 1930s even. And set up what we called in the 1970s, set up what we called the primary healthcare post, or puskesmas. We have more than 10,000 public-owned primary healthcare centers. Also, with the rise of the national health insurance, at present we have more or less the same number of private primary healthcare clinics. But unfortunately, that is never the priority of health sector development of the country. So access is still a challenge, and we are not even talking about quality. Quality is very different from big cities to rural areas. Some don't have health workers to work there. So when the pandemic hit, the system was not prepared to absorb such shock. It's political commitment. It's never appealing to talk about primary healthcare even at policy and political level, because it requires long-term investment. As government, you want tangible and short return on investment. When we talk about prioritizing primary healthcare, then we are talking about investing a huge amount of money to rebuild the system, increase the capacity of the people in it, and we don't know yet when it's going to come back, 10 years, 20 years, or even more. So that's a challenge. That's why it's very difficult to get consistent political commitment and leadership to focus on rebuilding the primary healthcare. The second one is, of course, resources. We need to follow political commitment with resources, and it is very difficult to continuing to putting in investments when you don't know when you are going to get that back. And of course, the third one is maintaining quality, because when we talk about primary healthcare transformation, it means maintaining access and maintaining quality. So because it's in primary healthcare, it doesn't give us justification to put in a mediocre quality. It needs to be the best quality as well, but affordable and accessible to the masses. I think it's very important to utilize this convening, this conclave, as ways for countries to become country chapters of this global learning collaborative. The more countries set up the country chapter, the more rich this learning collaborative become, because we have different perspective from different countries and their perspective action on the ground. So, for example, my organization's action is now exposed to this whole learning collaborative, and I'm sure there are so many out there. So that learning process is badly needed right now as we rebuild.